Welcome back, everybody. So we're talking for the next session about minimally invasive valve surgery and the merits or benefits and risks thereof. I think Hugo's had to go back, but fortunately we've got Ish, who's going to tell us a little bit about why we should be setting up a minimally invasive mitral repair program. Thank you.
Okay. I'm sorry for those people who were expecting to listen to Hugo van Ermen, but he's catching a flight. So my experience in this is primarily in my fellowship years. I've spent 2 years working with Steve Hunter in Middlesbrough, and also in my final fellowship I spent a lot of time working with Hugo van Ermen and Obadia in Lyon. So I'll try and give you my reasons why I thought it was important for me to learn this technique. As you know, basically we're changing from an ethos of open surgery to surgery involving working ports, peripheral access, to do the same operation that you would normally do through a sternotomy. And I can understand why established practices have been slow to change when surgeons can perform a very good mitral repair through a sternotomy and are having to learn through-port technology, different retractors, use endoscopic cameras, have a different team working with them in theatre, have to start to work learning to work with monitors, having a different perfusion setup, getting their anaesthetist to put in their superior caval pipe in, and also learning TOE such that they have control of the operation and placement of cannulae. However, like any adoption of new technology, it takes time. And these are words used by the industry: innovators, early adopters, early and late majority, and laggards. And I think in cardiac surgery, it's taken some time for us to adopt minimal access approaches. I think primarily associated with safety regarding these techniques. But as you can see, as uptake is taken up, the yellow line shows the percentage of procedures done as a whole. And I think we saw this previously when I looked at the literature in robotic prostatectomy and also in lap chole. In lap chole, it started in 1988, and within 6 years, it was the standard of care. This has been much slower in minimal access cardiac surgery and in mitral valve surgery. It's not a new technique. It was published in 1995 by Carpentier, Chitwood in 1996. Hugo van Ermen has been doing this since 1995. My first exposure was in 2004 when it was really starting to first come to the UK, and I was a trainee at that time. And now we're in 2014, and these are ballpark figures, but in the UK we're doing less than 5%. It incorporates less than 5% minimal access mitral valve surgery if you compare it to the whole of the mitral valve practice. Whereas in centres in Europe like Leipzig and in Hugo van Ermen's unit, the uptake is over 80%. I remember when I was in Hugo van Ermen's unit, there was one case where there was a sternotomy happening. And normally there wasn't a lot of people in theatre, but I remember all the trainees running into that theatre because none of them had seen a sternotomy for 2 or 3 years. So, what am I going to base my talk around? I don't have the gravitas that Hugo does to talk about his own experience, so I thought I'd try and stick to the data. And then what I'm going to try and revolve that around is looking at quality. When I think of quality, I look at safety, effectiveness, and patient experience. There's been 4 big systematic reviews and meta-analyses around this topic since 2008. I'll quickly show you the basic demographics of each one. I'll point out the first one by Modi and co. was looked at data between 1998 and 2005. One thing you do need to know about that study is that it did include low sternotomy and paramedian incisions as well, and that is really my only critique about that. It was an important piece of work, but very early at this time. Second one was in 2011. That looked at data between 1997 and 2010. They compared mini mitrals to sternotomy. The outcome data that all these meta-analyses are looking at is very similar, and I've detailed those on the left-hand side of every slide. Chow et al. In 2013 looked at data between 95 and 2013. They tried to limit their analysis just to mitral valve repair, which is degenerative, and tried to exclude those where concomitant procedures were published. And the most recent one, which is available electronically but not out in press yet, is Sundermann's this year. They looked between 97 and 2013, and they again looked at mini-mitral via minimal access thoracotomy compared to stenotomy, similar outcome data that they looked at. So what I've tried to do over the next few slides is just summarize all the data that we're getting in those. And I know this looks a little bit busy, but ND means there's no difference as the conclusion. S favors the stenotomy cases, and mini favors the minimal access cases. So if we look at effectiveness first, mortality, there was no difference in all 4 of those meta-analyses between stenotomy and mini-mitral. If you look at chest tube drainage in the later stages, this favoured the mini-mitral route, and as did transfusion. You'd expect transfusion to follow the amount of blood being drained. Now, in terms of reoperations for bleeding, this was highlighted as being favouring minimal access in the initial meta-analysis, but later on this has not been shown to show any difference. Same applies to renal and pulmonary data. Surprisingly, I thought AF would favour mini-mitral, but on the whole, the last 2 meta-analyses showed that 2 out of the 4 showed that there was no difference. The most recent one by Sundermann, there was a trend towards favouring mini-mitral, but this was not significant. Length of stay in ITU favoured mini-mitral. Total length of stay was equivocal, really, throughout. I think that really is down to the hospital itself and the real incentive to actually get patients to leave the hospital. And I think there's a number of factors involved in length of stay. I think we have to take that into account. And the important statistic in terms of freedom from reoperation in the studies we've looked at, there was no difference between mini-mitral and the stenotomy cases. If we look at patient experience, I think mini-mitral really is the favoured option here. There's less pain. This is pain measured in the first 2 days and also after that in hospital. Recovery is much faster. It's difficult to measure, but there was one of the 4 studies there. They looked at recovery and time back to normal functional activity. Obviously, the wound is smaller, so you're less likely to get any wound complications. And patient satisfaction, they were happy with the size of the wound, more so than in those who'd had the stenotomy cases. The only time where it does favour stenotomy in cases of patient experience is obviously groin complications, and most stenotomy cases do not have a groin wound. And in the initial mini-mitral cases, there were issues with lymphoceles and problems with cannulation, which contribute to that statistic there. Now, in terms of safety, it has been ratified by NICE as being a safe procedure to take on. But I want to discuss this a little bit more, primarily because there has been some issues in the literature. Neurological complications and dissection have been 2 issues that have been highlighted. And in the meta-analyses, although the latter 2 showed no difference, I think that's interesting because it actually incorporates taking into account data from more recent series where the learning experience has probably been overcome, whereas the initial series, they were still part of that learning curve, contributing to stenotomy being a more favoured feature when you look at these dissection and neurological outcome data. And in terms of cross-clamp and bypass, the mini-mitrals always take longer, and therefore that is why all 4 meta-analyses favoured the stenotomy cases. I think if we do end up coming to a discussion on this, I think a lot of this revolves around cross-clamping, whether they use the endo balloon, changes in technology associated with these, therefore, and the learning curve, therefore, this being a less significant factor in the more recent meta-analyses. We have to look at atheroma burden and whether retrograde perfusion actually affects this, and and for that reason, I just want to take 4 or 5 slides now to look at that, because I have a feeling that the next speaker may want to look at safety as a reason not to do minimal mitral access, and that is why I really want to be transparent and try and talk a little bit about this so we understand the data. Now, in GAMI in 2010 looked at 28,000 cases. Alarmingly, he reported a nearly twice increased risk in stroke. However, if you look at his data, the way they pulled out the data for mini-mitral was that they actually used femoral artery cannulation as their search term in the STS database to use as a surrogate for mini-mitral. So I think there's a confounding factor there. And also, if you look at the number of cases per centre per year that were pulled during that time, it was only 3. And I think both of these factors need to be considered when you actually consider that 1.96 figure. Then on that Cheng meta-analysis that I showed, there was a 1.8 times increased risk in stroke. If you actually look at the sub-analysis, all this increased risk was only associated with the use of the endo balloon, which was new technology at that time. And half of those cases were in the 10 years prior to 2003, so when this technique was really in its learning curve. We'll then go on to the New York University group, who again in 2011 and in 2010 published higher than accepted stroke figures for minimal access mitral procedures. In the first group, you need to realize that we're looking at a lot of redo cases here, and included cases where there were 2 or 3 concomitant procedures at the same time. If you actually take those out and just look at the isolated mitral valve figures, there's no difference in the risk of stroke in this publication. And again, they looked again in 2011, and although they found an increased risk of stroke, what they found is that if you look at the age groups, there's no difference in those less than 50. And in a documented discussion at the STS, they accepted that they think the mechanism of this was probably the burden of atherosclerosis. If you actually look back again at the meta-analyses and other isolated series, Chitwood's data, the more recent meta-analyses show a acceptable risk of stroke between 0.6 and 1.2%. If you look at the SCTS data for mitral valve surgery during the same time period, the risk of stroke published was the actual stroke rate published from mitral valve surgery was 1.4% in the UK. So, moving on, I think we need to really look at how we work these patients up to try to avoid those risks that we've talked about. And if you look at some data from the Cleveland Clinic, they screened 150 patients who were being worked up for minimal access mitral valve surgery and found that 1 in 5 had a significant subclinical aortoiliac atherosclerosis. And I think this is the driver for those neurological events when you're using retrograde arterial perfusion. And I think minimal access is not for everybody, especially initially, especially when you're part of the learning curve. And I think things like this are very important to try and select your patients to provide good outcomes. Atheroma burden needs to be assessed, and some of that data, as you've seen, is historic and is part of the learning curve. There was some learning curve data published late last year from Fred Moore. Interestingly, their conclusion was that you do need to do approximately 75 to 100 cases before your cumulative complication rate goes down. They looked at their 17 surgeons over 17 years and found different Q-sum analyses. Some of them showed a little bit longer to learn, as in the top one. The second one is their typical learning curve, and the third one shows surgeons that continue to operate there but needed extra mentorship from some of the more experienced surgeons to bring their cumulative complication rate down. Interestingly, probability for serious adverse events was higher if they were doing less than 2 minimal access operations a week, and I think this is an important factor to consider if you are going to offer this as a safe technique in the hospital that you work in. Cross-clamp times did not change according to the number of operations that were done, and this reflects in the same experience that I had when I looked at Professor Obadiah's and Steve Hunter's cross-clamp times, there was not a massive change in those as they progressed with their learning curves. There's a number of pitfalls, and I think to provide a safe, effective service, there's no reason why you can't, because there's effective mentorship available now. There's different technologies. There's plenty of European mentors and UK mentors available to avoid these simple errors that were happening in the early part of people's learning curves. Now, in terms of training, if you look at the trainees in your unit, a lot of the time, taking up new technology affects the training of standard procedure cases for these individuals. I actually felt when I was in my latter stages of my fellowship training that in this technique I actually got a better view of the mitral valve than standing on the opposite side of the Cosgrove retractor. I actually learnt more from the screen in those cases that I was not operating on than if I was just assisting a normal case. I think it's the only type of minimal access surgery where you get a better view on the screen, and it actually provides an easier environment to put the stitches in than a sternotomy technique. You can actually get inside the ventricle and see the papillary muscles and put your stitches in the appropriate places, as shown by Hugo at the lunchtime seminar. I'll skip this slide because I know Paul is going to run through his stages of learning. I'll go through that. There is data as well to show that it's appropriate to use in redo cases. If anything, it might be a safer technique. You don't have to. You can go through virgin tissue. There's definitely a lower bleeding rate associated with mini thoracotomy once you've been through the sternotomy before, and it is possible to do the whole gamut of cases: tricuspid, air fibrillation, and ASD once you get more experience. So I don't think there's any real reason not to set up a program right now. It's a reliable technique. Nowadays, compared to 6 or 7 years ago, it is well established. There's plenty of support from good mentors in Europe and the UK. The safety profile has started to improve, and we've started to learn why the initial data shows the increased poor neurological outcomes. There are excellent results, and it's a patient-centered approach. There's less transfusion, duration of stay has been shown to be reduced. There's hardly any sternal complication, and speed of recovery is definitely better. There are caveats, and I don't think everybody should be jumping into this without learning from dedicated mentors over dedicated time periods, without knowing what the complications are of this. But I think, like a lot of different technologies, it is something that is going to come. CABGs have reduced in the UK, and valve procedures are increasing. Cardiologists are starting to take on more and more valve procedures, and I think, like a lot of minimal access technology, we do need to take it on board, otherwise it will just be taken away from us. Thank you.
Thank you. That's me. Okay, any questions about that before we move on? Who in the audience is doing minimal access? Are you enjoying it? No. David, yes.
You should be here.
You can just give us a 1-minute summary of the advantages of that approach, but everything you've been talking about. Spent a lot of time defending things that we know happen, assessing that to learning curve and 4 centers instead of big papers and whatever. But what specifically do you tell a patient today is worth going through that learning curve, the slight increased risk, the burden of atheroma, the pre-screen to make sure we don't increase your stroke rate? You're giving them all that stuff if you're giving them an informed consent about the bad things that can happen. So what do you actually tell them are the proven good things that can happen?
I think recovery. Time to recovery is markedly quicker. They recover in 3 weeks compared to 3 months.
Are you comparing, again, like I told you, the full page? I can put my book through your chest incision because you're using a Cosgrove that has 6-inch blades, therefore you get a 10-inch incision and you get open to the mid-axillary line? Are you comparing an incision this big that's open this wide with a pediatric retractor? When you say it takes 3 months to heal, I always hear that, it takes 3 months to heal. I've never read a paper that says that. So when you say that, what kind of incision are you comparing when you compare the minimal access incision that you can play golf in 3 weeks and the 3 months that you're going to spend in a hospital bed after sternotomy?
I think I have to read from the data that's available, and from the data that's available from the 4 meta-analyses that I've looked at, they compare mini thoracotomy with full sternotomy, and from that data, that is where the summary of reduced transfusion, less blood loss, faster time to recovery, fewer infections comes from.
Yeah, I think, you know, what I would say is that what I learned from that whole field is that we don't need to make a 12-inch incision in everyone, and we should stop making these 8 and 10-inch incisions by the first-year guy and putting a giant retractor in. They should be small, measured incisions, just enough to get access to the left atrium and do the operation. So you don't need to see the left ventricle, you don't need to see the lungs, you don't need to open pleural spaces. And I think when you compare that, then I think that advantage is going to be minimized. The cosmesis you can't get around, particularly in women. It will be more cosmetic, but the other stuff I'm less convinced by in modern sternotomy.
Ish, can I ask you a question? You've shown some fairly compelling data there, I think, about the optimal volumes you need to be doing on a regular basis to have optimal outcomes from your mitral repair program. You've also shown the volumes that you need to do to get up to the top of your learning curve. And the reality of that is that most surgeons in the UK are not doing that volume of mitral valve repair surgery, so they do not have the volumes to be safe, and actually it would take them in excess of 3 years to get at the top of their learning curve. I can buy those arguments if you have centres who are doing 150 mitral valve repairs a year who want to start up a program, but I cannot buy that argument very well when we know that the median number of mitral valve repairs per surgeon in the UK is very much less than 25 per year. Any comments on that?
Yeah, well, I think we've had a lot of discussions today in terms of numbers of procedures and competencies and quality of data that's coming out of mitral centres, and I'm with you on that. You know, if people are doing this kind of procedure, we know the learning curves associated with it, and I think if we are going to take on minimal access mitral valve surgery, then those surgeons who have the skills need to be connected with those centres that have the volumes to provide the best service with the patients.
Ish, can I just... Sorry.
Can we set the audience?
Ben, I think you made a very good argument there why this is an operation that needs to be concentrated in high-volume centres. It's a subspecialty in surgeons who do, first of all, a lot of mitral valve repair, but then have the volumes to do a lot of minimally invasive repairs, but who've also been through a training program of 6 months to a year to traverse the learning curve. The problem here with this operation is the learning curve, and that you can have a proctor with you for 4 or 5 cases, but as Fred Moore's data shows, the learning curve is 75 to 125. So you've still got another 100 cases to go on your own before you even through the learning curve, and that is the problem.
Could I stop this? Because Steve is going to address a lot of this, I think, why I shouldn't set up a minimally invasive program. Exactly. So let's stop this now, because we're so far behind. But perhaps some people might reflect on the fact that a well-done sternotomy does not have huge blood loss. It should, in fact, my blood loss or PAPA is the lowest of all the surgeons there. So you can do it with a very simple technique to keep it dry. So should we move on to the next talk? Thank you very much. Yes, that was very well done, very well put. How shall I set up a minimally invasive program?